Hello and welcome to today's webinar for mental health professionals, Introduction to Affirmative Clinical Practice with Sexual Minority Clients, featuring Dr. David Pantalone. My name is Vicki Spielman and I am the Associate Director of Membership and Education at ADAA. Before we get started, I would like to go over a few items so you know how to participate into today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's audio by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted for the entire presentation to avoid background noise and distractions. You will have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. For those who purchased CE/CME credit for this webinar, you will receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive a CE/CME certificate. Please reach out to webinars@adaa.org if you do not receive this link. I would now like to introduce Dr. David Pantalone. David Pantalone is a professor of psychology and associate dean of the College of Liberal Arts at the University of Massachusetts, Boston. He is an affiliated investigator at the Fenway Institute of Fenway Health, the largest sexual and gender minority-focused healthcare, education, and research facility in the U.S. Dr. Pantalone has been a co-principal investigator for numerous NIH-funded studies. Most of his work is centered on developing behavioral intervention to improve outcomes for those affected by the U.S. HIV epidemic, especially sexual minority men. Dr. Pantalone has co-authored approximately 120 scientific publications and 170 clinical research presentations. He is a fellow of the American Psychological Association, sits on multiple journal editorial boards, including the Journal of Consulting and Clinical Psychology, and serves as associate editor of the journal Psychology of Sexual Orientation and Gender Diversity. Thank you for joining us, Dr. Pantalone. There will now be a brief moment of silence while I pass the presenter role.
Okay, hello everyone. Can you hear me? I hope you can hear me. Thank you for that introduction. I feel embarrassed now. Oh, got a note that we're good with sound. Great. Okay, so, and can you see my slides?
Yes,
Great.
everything's
okay.
good.
Excellent, thank you. All right, so I want to minimize. Okay, thank you all for coming. I wish we were all together in a room and not in a webinar, although the webinar format was planned even before COVID times. So here's what we'll cover today. Five main points. The need for cultural competence for sexual minority clients. We'll focus on terminology and the underlying concepts. We'll talk in general, briefly, about working clinically across difference. And I'll touch on some of the considerations for providing sexual minority affirmative care, noting that we only have an hour and there are many, many books, on this topic. So my goal is to show you some resources and introduce you to some of the ideas. And the last bullet is about how to learn more. So I have a few suggestions that will come in at the end. Okay, so there's been a lot of talk in mental health professions in recent years about cultural something, right? Cultural knowledge in terms of acknowledging characteristics, history, values, beliefs, and behaviors of another cultural group. So knowing about another cultural group. Cultural awareness, being open to the idea that we might look at changing our cultural attitudes about members of another group. Cultural sensitivity, so this is knowing that differences exist between cultures, but not assigning values to those differences. And cultural competence, using knowledge and skills to provide more effective services to individuals from cultural backgrounds that differ from your own. And that's the hook definition. But I would say even when we're doing clinical work with people who share our backgrounds, that doesn't mean that we somehow are culturally competent to deal with them necessarily, because having a shared identity doesn't mean having shared experience. So cultural humility, this is the order of the day. And so it's essentially cultural competence plus. So it's the cultural competence elements plus understanding our own power, privilege, and prejudices. So taking more of a system view of oppression, not just at the individual level, and being willing to accept that acquired education and credentials alone aren't sufficient. There's no stamp of cultural competence. And so one of the elements that makes cultural humility really different than any of those other categories is the part that's a lifelong commitment to self-evaluation and self-critique, a desire to fix power imbalances where none ought to exist, and a commitment to developing partnerships with people and groups who advocate for others. And so in 1 hour webinar, I can really try and focus on that cultural competence part. And I'll leave it to you all about whether you turn the cultural competence content into cultural humility to move forward. Okay, I'm going to say a little bit about the mental health of sexual minority individuals. And so homosexuality was actually in the DSM until 1973, and it only left the DSM because of vigorous advocacy from psychiatrists via activism. And now having a sexual minority sexual orientation is, a gay, lesbian, or bisexual identity is considered a normal variant of human behavior by mainstream scientific and professional communities. It's challenging to know about the mental health of sexual minority individuals because sexual minority individuals are a hidden population. That is, one's sexual orientation is concealable. And there's a big literature about the stigma of concealable identities. So it's different than being a racial or ethnic minority individual, where it's a non-concealable identity. And so what that means is for folks who try to study the mental health of sexual minority individuals and try and say things like more gay men have symptoms of depression than heterosexual men, it's hard because it's hard to know how many gay men there are. You've probably heard estimates that date back to even the Kinsey times in the 50s of about 10% of the population. And I think all of that really just depends on what the survey methods are and how the questions are asked. And we'll talk a little bit about that. So just to say context matters, that sexual minority folks have had some wins in recent years, like the repeal of that's don't ask, don't tell, and that Windsor Supreme Court decision that legalized gay marriage a few years ago, and a huge effort through the VA healthcare system to improve services for LGBT veterans. And so those are some wins. There are other battles, though, that still continue, like the military service for transgender individuals that often shows up in the news, and my colleagues at the VA are fighting so hard to help trans veterans to get the healthcare that they need. Discrimination that occurs in healthcare settings, and so I used to have this one that said no federal protections based on sexual orientation in employment settings, but there was a recent Supreme Court case, so at least for now, that's a win, actually. There's not really enough funding to examine sexual minority mental health disparities, and that in some of the big national surveys, depends on the kind of political order of the day about whether or not they're measuring sexual orientation. And so in some of these surveys, we could have a lot of information about who has a sexual minority identity and who doesn't, but those questions just aren't asked. So it's hard to know a lot of the answers. But when you do look at the literature that we do have, we see significant, stable health disparities for sexual minority individuals. And that involves in the area of physical health. So in terms of physical fitness and cardiovascular health, in terms of sexual risk behaviors that lead to HIV and other STIs, even in terms of cancer, which probably has more to do with lack of engagement in medical care than anything else. And there are also significant stable health disparities for sexual minority individuals related to mental health. And that's about alcohol and substance use, including tobacco dependence. The last I looked, it could be different, but that sexual minority folks were the only population where as age increases, the proportion of the population who are smokers also increases. For most other demographic groups, that goes down over time, which is to say young people smoke more than older people. It's not true for sexual minority folks. Those mental health disparities also include, unfortunately, interpersonal violence and mental health issues, but really especially depression and suicidality. And it's important just taking a step back and thinking how context matters to think this is a population where there are active debates in the media and in politics about whether or not this group actually deserves civil rights. And so when you think of it like that, you can think, well, I wonder how those debates impact people's mental health. So there's this need for cultural competence for sexual minority folks. So these sexual orientation related health disparities are well documented, including depression and anxiety. And the data indicate also that many sexual minority individuals have had negative experiences with healthcare providers in the past. And so that's one kind of strike against us collectively as providers, which means that when a sexual minority client comes into your sphere, they might be carrying with them the baggage of previous negative experiences. And so it isn't necessarily something about you and whatever you're doing, but just that they've had those experiences or heard about them from their friends. And so it's critical for us to deliver culturally competent care in a professional and respectful manner. And so the question for today is, how does one do that? So professional organizations have disseminated guidelines for working successfully with sexual minority clients. However, the guidelines are generally based on a review of the existing literature and not on those kind of gold standard research designs that are called randomized trials or randomized clinical trials. And so that means it's good evidence, but it's not the best evidence, but it's all we have. And so that's what we've been trying to summarize in the literature for folks. And I note, in addition, or perhaps as a consequence, mental health providers report that their clinical training programs have generally not given them the training that they desire or that they feel like they needed in terms of building cultural competence with sexual minority clients. And so this is also a challenge, of course, because the structured training is where most training happens and where it's kind of regulated by the professions. And so what this means is that the training community has kind of outsourced the training in sexual minority cultural competence to continuing education workshops like this, which are shorter in duration. And so just noting that if you're in a training setting, in as much as you can put out some materials, or make changes to the curriculum related to increasing treatment of sexual minority cultural competence, I certainly encourage you to do that. Okay. Yep, I said that. Okay, so there's a model, a theoretical model, although it's actually based on a lot of data also, called the minority stress model that Ilan Mayer, who's a social psychologist, developed in the 90s, and that a lot of us have spent our careers investigating since then. And I'm going to advance the slide and you'll see it, and then it kind of looks like a mess, but we'll just take it part by part. So that's what it looks like from his 1995 article. And here are the important parts. In the model, it says what matters in terms of mental health outcomes are both things that happen in the environment, and especially things that happen in the environment related to important identities like sexual orientation. And that's like these public debates basically about the civil rights of sexual minority folks. And so then sexual minority folks also experience general stressors. And so this is one important thing if there are trauma folks in the audience that we often talk about, how having a sexual minority identity means that folks have additional stressors, but no fewer of the general stressors, right, that everyone else has. And so then there are these minority stress processes. They're called minority stress processes in general. And so one category there is about prejudice events, which is like the discrimination and violence. So hate crimes, essentially. And those are those distal minority stress processes. And then I know it's a little jargony, but we won't spend too much time here. But then there are these proximal minority stress processes also, which are expecting rejection, concealing one's identity, and internalized homophobia, or internalized heterosexism, it's sometimes called. And that all of this points to these mental health disparities. And so I think just taking a step back, the important takeaways are sexual minority folks experience the same general stressors, plus additional stressors like prejudice events that are related to their sexual orientation, plus a way that they've internalized those stressors and the context that folks are living in which they're expecting rejection, concealing their identity, and managing this internalized homophobia. So there's a lot of work for sexual minority folks to potentially do in therapy. Coping and social support, both at the community level and the individual level, is a really important element also that kind of moderates or attenuates those associations. So basically a lot of coping, good coping skills and a lot of social support can prevent some of those negative mental health outcomes. So this is the minority stress model. In a lot of readings that you might do about the mental health of sexual minority folks, this model or components of it will probably be referenced. So just want to talk about some terminology. Language is important, of course. And if we were in the room, I would pose this question to you. What do we do when we aren't sure what words to use about an identity, a behavior, or something else? And eventually one of you would say, or soon one of you would say, we don't ask about it because we're uncomfortable. And that's really common, of course, because if you say the wrong thing, you'll harm the client irreparably forever. Just kidding about that part. But it is important to note that that's often what's going on for lots of us, which is to say, when we're not sure what to say or how to say something in a way that would be that we know would be taken respectfully by the client, then sometimes we just don't ask. And as you'll see from some of the data that I present later, clients notice, sexual minority clients notice when we don't ask them about their sexual orientation. So let's talk about sexual orientation. So sexual orientation is this plays out in language in terms of lesbian, gay, bisexual identities, so LGB, which we sometimes hear a lot. Often we'll hear the T added to LGBT, lesbian, gay, bisexual, and transgender, and that's an interesting point because many sexual minority folks, so LGB folks, some are transgender. Some transgender folks are LGB, have a sexual minority sexual orientation or a non-heterosexual sexual orientation. But actually, sexual orientation is kind of on one axis and gender identity is on another axis. And so everyone has one of each. And they might change over time, but everyone has a sexual orientation and everyone has a gender identity. So I think sometimes that LGBT, when it's together, it can imply that transgender is like a sexual orientation when actually it's a gender identity. So that's some of those terms. I have a slide in a couple that talks about some kind of antiquated terms, but you've heard me use that term sexual minority a lot. And it's a little academic. I'm not sure that clients really use this term, but in the published literature, this is a term that gets used a lot. That's a kind of umbrella category for any non-heterosexual sexual orientation. So for the LGBT kind of community writ large. Sometimes you'll hear LGBTQ, and so sometimes I'll get questions about what the Q is, and that sometimes it means questioning, and sometimes it means queer. And queer is one of those terms that that folks in different age cohorts have a different history with. That for some folks who are a bit on the older generations, they knew queer as a slur, but especially the younger generations and on college campuses, it's a term that's been reclaimed by a lot of sexual minority folks. And so I think if you fall under the LGB umbrella, if you are a queer person, probably okay to use queer. If you're a heterosexual person, you might think about using other terms instead, but it could still be fine depending on context. There are emerging sexualities and language shifts. And so this is to say that for a while in my career, LGB and heterosexual, those kind of were the sexual orientations, but it just isn't true anymore. And we just get pushed often by the younger generations to have who use different terminology, and then the kind of fuddy-duddies in the research world, and we eventually take them on, but it's not always as quickly as they would like. Or so, for example, there's a term that's come about, allosexual, which means having sexual attraction towards people, versus asexual, which is not having sexual attraction towards people, or at least not under certain circumstances. And so for a lot of us, we might have learned kind of in psychopathology class that low sex drive, low libido was a sexual disorder that needs to be treated. But this is partly how things are changing. And so we see in young people and even more middle-aged people identifying as asexual as a sexual orientation almost. And so not something to be treated, but an identity. And other terms like gray sexual and pansexual. There are other grouping categories, monosexual and non-monosexual. So a monosexual individual would be a lesbian, gay, heterosexual person, and a non-monosexual person or a member of the bi plus community would be a bisexual person or pansexual person. So it's really, there's so much, the terms change all the time and people's understandings of them are often so overlapping. And so whenever I'm working with clients and we're talking about sexual orientation terms, I always just make sure to ask people how, what the identity means to them. So having a gray sexual client, meaning mostly asexual, but not exactly. So asking, what do you mean by that? Just so I can make sure I understand. There's also a lot of, say, guidance from good old Kinsey, that one of the things that was really useful about, that has remained useful, I would say, about the work that Kinsey did in the 50s was breaking sexual orientation into a few different categories. So breaking it into attraction, identity, and behavior. And that those different dimensions, those might play out differently for different people. So a person who identifies as heterosexual may be attracted to people of the same gender as they are, meaning that they might be considered gay, but gay is a sexual orientation. And so their identity may be heterosexual, but their behavior and attractions may be more complicated than that. And so it's also good practice when you can, to the extent that this is a dimension of treatment that you're working on with clients, to kind of get at those different parts, the attraction, identity, and behavior, and not to assume simply because we know about one of them that means we know about the other two. And a more recent addition even to the literature is this idea of romantic or affectional orientation. And so that some people are breaking down what we think of as sexual orientation as into a romantic part and a sexual part, acknowledging that for some people those are different, and that they might be different at different times for them. So all of this is also just with the caveat that there's a lot of really interesting research that talks about how sexual orientation can change across the lifespan, and maybe not just in the ways that we would expect, like like younger people maybe identifying as heterosexual and then going through an identity development process and then identifying later as one of the sexual minority identities, but really having it be more complex than that. Lisa Diamond is a developmental psychologist who's done a lot of really interesting work on what she calls sexual fluidity in women especially. And her work has shown that for some women, the specific relationships are more important than a sexual orientation. And so that a woman might sort of like retrospectively identify as lesbian because of having had a relationship with a woman or being interested in having a relationship with a woman. So I tell you all this to say that it's complicated. And I think I say this in a few slides, but it's complicated even for those of us who do this all the time. So, but I also did want to have a focus on gender a little bit because of some of that confusion that comes up in terms of LGB versus T. And so gender and sex are also different constructs that sometimes get conflated. And so gender is the social construction, right? That's male and female. And so that's when we know that there are boy things and girl things. That's gender. Sex is about biology. And so often when we're talking about biology, for those of us who are doing like this in the research world, we're asking what was the person's sex assigned at birth, which is essentially a politer way of asking what genitals they have, right? What secondary sex characteristics they have. But biological sex, which a lot of times people think of it as being binary, you know, born a man or born a woman, that it's actually more complicated than that too, that there are multiple levels, biological levels of sex. So for example, a person could hormonally, you know, that their hormones might be out of sync with their secondary sex characteristics. And these are some of the disorders that come up. They get characterized as disorders in the DSM, but just noting that it's complicated. That kind of, we think about gender as being complicated, and then we think about sex as being very clear, but actually that's not clear either. I think a lot of times we talk about, there's just a lot of language that's really common, like both sexes, for example, which reifies the gender binary. And so for some of us, it makes sense to think of the world as male and female. But for a lot of people, they don't experience the world that way, either for themselves or the ways that they perceive other people. And so you see a lot more of people identifying as agender or identifying as non-binary, meaning that their gender doesn't quite fit male or female. And so I think it's important to check in with folks about what language they prefer in terms of pronouns. And the best way to do it is to ask, what pronouns do you use, or what pronouns should I use for you? There was a movement for a while about asking about preferred pronouns, but then there was a kind of pushback from the transgender community about saying, well, we don't ask about, you know, preferred sexual orientation or, you know, other kinds of preferences, that it's not a preference, it's their gender. So so that part is important. And one way that we suggest addressing, one way to address that is to start by sharing your own. And I've seen this more and more in settings when during introductions, if folks say, hi, I'm David, I use he, him pronouns, or I use male pronouns, to kind of model for other folks about how they might do it as well. It opens the door. And just acknowledging that pronouns can change over time. You have this happen with clients and with students in our programs, that they come in with one gender identity and then they have a different gender identity later, or have a different set of pronouns that they use. And so it can be important to recheck in with people about them. I said the preferred part already. And there's another terminology thing, which is, it used to be that people talked a lot about kind of a sex change, but really the movement is more to talk about changing gender. And then the terminology was about a gender transition, that is to go from one thing to another thing. But even that terminology has had some critics, which I think is interesting and makes sense too. And so folks are now using more terminology like a gender affirmation, because gender transition implies that the person was one gender and now they are a different gender. When for the person whose gender we're talking about, they may have experienced their gender the same forever, but it's just that their sex assigned at birth wasn't a good match. And so, so gender affirmation or gender affirmation process are terms that we've heard from a lot of trans folks that they prefer. So just that there's antiquated terminology too. Folks don't really use homosexual anymore. Most of the way that term is used anymore is kind of anti-gay rhetoric. And so sometimes the use of that term can kind of set off the spidey sense of sexual minority folks who would then be hypervigilant about whether they're about to be discriminated against. Anything that has to do with lifestyle that just makes sexual orientation seem like a choice, antiquated. Sexual preference, that same, just like preferred pronouns, that it just doesn't fit the experience for folks now. Another kind of generational one, using friend or lover instead of partner, girlfriend, wife, for example, and that some folks feel like it kind of demeans the relationship to not elevate it to a more important status. I mean, we could have a different conversation about whether there's really a hierarchy of relationship statuses, but anyway, it's an important one. And then any constructions in which a sexual orientation, really, or gender identity is used as a noun, so like saying that that's a gay, and not as an adjective, so a gay man. So those are just some examples of the ways that terms change. And again, you might be in contexts where using these terms are common. And so the question is just, are they commonly used and appreciated by the queer and trans folks in that setting, or are they commonly used and not appreciated in those settings? So take-home messages that sexual orientation, gender identity, distinct constructs. They've long been considered categorical. That is, you fit into one category and you have that category forever. But the more emerging conceptualizations really for both of them are more dimensional, more complicated. Assessing, I moved these slides later, but we'll talk a little bit about assessing sexual behavior. It's a necessary but not sufficient element of competently addressing sexual orientation. And really just understanding that language is ever evolving. And just noting that it's generally under-addressed in training programs. And I always say, like, all the stuff I learned in school is outdated anyway. So it's useful to have refreshers through events like this. And I say it's confusing for all of us. And open-ended questions work best, which is often a forte of mental health providers anyway. Okay, so with that as a long introduction, I want to talk a little bit about working clinically across difference sort of in general. And if we were together, I would ask you, and we would have a discussion about how you work successfully with clients who are different than you, how you think about it, and then what you actually do. So really thinking like, what are the steps that we take when we work with people who are different than we are? And I've added this part because I've seen it happen with a lot of the trainees who I supervise, but thinking about what to do when they receive feedback from a client that they've inaccurately addressed some part of their identity. I like this phrasing. I can't remember where I learned it, but basically consider it a gift and commit to doing better moving forward, because for folks with marginalized identities, it can be challenging interpersonally to bring up a slight like that. And you could assume that the person is bringing it up because they care about you and care about your relationship. So I like thinking of it as a gift, even if it makes me feel anxious. The big picture in terms of working clinically across difference, and everyone has different ways of doing this, but these are some ways that I like to think about it, is to start by doing what you'd typically do in terms of addressing any clinical issues. And so that content, the what, is there. But then second, aim to tailor the approach to the unique cultural context of the client. And so you have your what, and then you have your how. So the how is that cultural tailoring. I have a chapter with Gail Iwamasa and Christopher Martell about working clinically across difference from a CBT perspective. And this is the advice that we give. We posit that a skillful clinician who practices cultural humility holds these two seemingly contradictory strategies, a dialectic, if you will, if you're a DBT person. So on one hand, you want to become knowledgeable about the groups to which a client belongs, but you don't want to ask the client to provide that education, because that situation could itself be a stressor for minority group members. So to say, tell me about queer people, teach me about queer culture. that some folks would even consider that a microaggression, really. And at the same time, acknowledge that a given individual's experience of the world is unique, and it isn't determined by their group membership alone. So we say people are members of sociocultural groups, but they're also uniquely individual. And that's an important element, I think, to think about. That's whatever learning we do, the kind of generalizations about cultural differences. It's important to always acknowledge that the individual may subscribe to some of those generalizations and not others. So there's also excellent guidance from the SUS that awareness of one's own attitudes and beliefs is essential, as well as appropriate helping skills. So just to talk about what do we do? So I like to include that part as a way of thinking about working across difference. And then in the next section, we'll talk about how to actually do that in some senses. So one note is that all of the major professional associations, all of the medical and mental health professional associations have taken positions against reparative therapy or other kinds of sexual orientation change efforts. That they're not successful based on the evidence, and they're actively harmful. And a lot of those professional associations actually consider them unethical. So that's something not to do. What we really need as we're thinking about intervening with sexual minority clients, if you kind of harken back a little bit to that minority stress model, is we might need structural interventions or societal level interventions that say, that mean that there's less discrimination, right, in the world. And so in some of my work, one of my research programs is about coping with discrimination intervention for sexual minority men of color, so for Latino or Black men. And part of how we talk about it with the clients is through this kind of burning building analogy, that it would be better, so that having a sexual, having a kind of marginalized identity can be like being in a house on fire, where the building is burning. You need to put the fire out, but you also need to take the person out of the house, right? And so these structural interventions, like legal protection, like we're talking about, laws, passed by Congress or state legislatures, and upheld through the judiciary, that those are important. Gay-straight alliances, GSAs, those are important. Those structural interventions are important. But for a lot of us, the settings that we're in and the kind of training we've had, we intervene more at the individual level. And so, so the question is, yes, it would be better if there were less discrimination, and we can all think about how to make that happen. But in the meantime, there is discrimination. And we do have clients who come into our offices and they do need our help. And so the question is, what do we do then? So, I really like this Wilkerson article because it talks about some really concrete things you can do in the clinical context. And so I added the pre-COVID part, but the question is, what are the features of your clinical environment that signal that it's an affirming environment to sexual minority or gender minority clients or potential clients? And just kind of keeping in mind this idea that for a lot of folks who've had bad experiences in the past with healthcare providers, and they may come into the setting with you with their kind of nervous about what might happen and scanning the environment. So what are things that we could do in the clinical environment to try and decrease some of that arousal? And so Wilkerson and colleagues talks about three different elements. One is the structural environment. So what it looks like in the waiting room and in the offices. That is, are there visual cues of a sexual minority affirming stance, like a sticker of a rainbow or a rainbow flag, or LGBT affirming images on posters? So, two men holding hands or something. Are there magazines like Out or The Advocate, or other magazines that focus on sexual minority issues? And are patient education materials, like if there are handouts, do they use kind of heteronormative language, like assuming that a male person has a female partner or assuming that a female person has a male partner? So So folks are kind of looking for those visual cues. Another example of a structural environment kind of intervention would be having single occupancy restrooms. And then important to pay attention to staff behavior, but of clinical and non-clinical staff. That one of the things that I've heard quite frequently is, oh, my doctor or my therapist, they're really cool, but the person at the front desk seems less cool, about my sexual orientation or gender identity. And so really important, I think, to attend to the other elements of the clinical environment, like the non-clinical staff. So then there are elements of the systemic environment. So the mission statement and policies of your setting. Do they acknowledge sexual orientation diversity or gender identity diversity? Are there policies that mandate or encourage sexual minority affirmative staff training? Are folks required to have a training like this or something even longer? And then also intake forms. So, the kind of old standard intake, what is your sex, male, female? Maybe not even asking about gender, or asking about sex and gender, but only having male, female as the options, and not allowing a write-in or not allowing choose all that apply. That those kinds of forced choice options now don't match the way a lot of people understand their sexual orientation or gender identity. And so for a lot of us, for the researchers among us, we like when things fit neatly into boxes, check yes, check no. And so this makes it harder, but it's also important to, have an affirming stance and to accurately capture folks' experience, their internal experience. And so we've had to make lots of changes like that. And then the interpersonal environment, so how we interact with clients, using language that doesn't assume a heterosexual or a cisgender identity. So, asking about a partner, not using pronouns. And again, asking about folks' sexual orientation or gender identity in an open-ended way. That those are ways that you could signal to a client that you're open to them not being heterosexual or not being cisgender. When we're in the room, I like to do a self-reflection question, which is, can you think of anything in your clinical environment that you might want to change? And then I ask people to make a public commitment. And so we're in the segment of the webinar where it's just a one-way conversation. So it's just me talking, but just wonder if you might all think to yourselves, after this is over, about whether there's anything that you might want to change, just in terms of thinking of those prior slides and thinking about any of the things that you could possibly change, and then change it. So there's also this question of what to do in the therapy room, right? And some doctoral students who I worked with in the past did a really interesting study on this, where they recruited a relatively big sample, a couple hundred LGB folks from across the country for a quantitative survey. So they're filling out these, this is a web-based study. So we got folks from all over, and they reported on their mental health and other things that we published on. But we also included these open-ended free response questions where we said, have you had therapy? And if so, what did you like about it? What was helpful? What did you like about your therapist? What did you like about the therapy they did? And so the results are so interesting. And there's a lot of research, I should say, that asks therapists, what do you think clients need? What do you do with clients? Sexual minority clients. And so there actually, interestingly, hasn't been as much from the client perspective. And so, this paper, exists. So what folks said when we did a qualitative analysis, and so we had these hundreds of comments from these hundreds of participants, and looked at the ways in which they fit together, they really fit into two big ideas. One big idea is general person-centered psychotherapy competencies. And so that's probably, which was good news to us, since in terms of training therapists, that we're often training people in that anyway. So that's good. And then they talked a lot about particular aspects of sexual orientation that are relevant in therapy and should be addressed directly by therapists. And so I'll say a little more about that on this next slide. So there are those foundational counseling skills, right? That big idea one: listening, validating, creating a safe, non-judgmental environment, et cetera. Therapists allowing clients to seek answers for themselves, engaging in Socratic questioning, encouraging self-direction. So really that the client-centered or person-centered competencies. And then there's this other part where they talked specifically about sexual orientation. And so clients noticed the quality of how therapists addressed sexual orientation. They liked it when therapists openly addressed sexual orientation, when they actively affirmed their sexual orientation, if they didn't pathologize their sexual orientation. They didn't like it when therapists were inactive about sexual orientation. Honestly, it seemed whether or not it was relevant to their clinical presentation. And so that part was interesting too. They of course didn't like it when therapists negatively categorized the client or stereotyped them based on their sexual orientation. And they liked it when therapists accurately recognized when sexual orientation was unrelated to therapy goals. And that can be a difficult thing to tease out, and not something that there's an easy answer for, other than to ask a lot of questions and approach it with an open mind. So sexual minority identity, so another of the small ideas under the big idea too, sexual minority identity development occurs through social relationships. And so therapy helps the client explore their identity. Therapists work to help decrease shame and internalize homophobia. They help the client navigate the coming out process. So they liked when therapists did those things. They often wondered about the therapist's knowledge of sexual minority culture, if you will. And they liked it, of course, when therapists were knowledgeable about sexual minority culture and when they used that knowledge to make referrals. And so, if a client was, for example, having suicidal ideation and the therapist wasn't available for crisis calls, that they would not just give a kind of standard suicide crisis hotline, but that they might give a sexual minority specific number like the Trevor Project or something. So that part, that was interesting. And the therapist's sexual orientation was seen as relevant. And this one's ambiguous on purpose because there wasn't agreement. It wasn't like therapists should always say their sexual orientation or that they should never say their sexual orientation. It really seemed like it depended on the context. And so I think that's a clinical issue, to think about and talk out with colleagues and try and make decisions, based on what's in the best interest of the client. But there's no hard and fast answer there either. So I just note some sexual minority specific topics that can emerge, like coming out. Often folks have a lack of role models. We say that often sexual minority folks are the only person with a sexual minority identity in their family. So it's not like being a person of color where the family can say, this is, I'm sorry that racism will happen to you. It will happen. And we'll show you and tell you about how to manage that. So there often aren't role models in terms of managing, sexual orientation related discrimination. And that can result in these feelings of sort of social isolation, which then, feeds back to thinking about that minority stress model, so maybe some of those sexual orientation related mental health disparities. Bullying for gender non-conforming behavior or having a non-heterosexual sexual orientation, or folks even assuming or inferring that. And so there's a lot of bullying based on gender, really for all genders, but especially for male identified folks. As you likely know, there are a lot of, there can be rigid ideas about what it means to be a man, and the social consequences for not conforming to those ideals really clearly can be challenging for folks to manage. Non-traditional relationship structures like open relationships or other variants of consensual non-monogamy, these can be more common among sexual minority folks. But some sexual minority folks, they're kind of like, oh, monogamy is for heterosexual folks, and so I don't really subscribe to that. It's sort of interesting, would be interesting to do work in that area to really kind of tease apart how ideas about relationships vary with sexual orientation. We talk sometimes about chosen family. So in families where there's a lot of rejection based on having a sexual minority sexual orientation, queer and trans folks might choose a family. And so we talk about it as chosen family versus biological family or family of origin. And so talking about family can be complicated. And if we only think about biological relatives, it might not fit the reality of our sexual minority clients. There are unique stressors related to parenting. I mean, and this just goes on and on, really, that laws are variably supportive, about, for example, second parent adoptions, and some queer folks might have kids from prior relationships, and so, might not be biologically related to their current partner. And so just a lot of complexity there that can make for rich therapy content. And then, of course, discrimination in the world, but in healthcare settings also. Sexual orientation is about more than just sex. So that's another point that I wanted to make. But it's about sex sometimes. And so I think another element of addressing sexual orientation, it can sometimes be talking about sex, which often is uncomfortable for us. And so just note some thought questions, like what parts of assessing sexual behavior are you more comfortable with or less comfortable with, or are there certain clients that make you feel more or less at ease? And then some phrasing. We've heard this from clients, that some kind of progressive phrasing they consider dated, especially the young folks. I'm telling you, the young folks really keep us on our toes. Asking this question: do you have sex with men, women, or both? And so it is affirming, of course, of the possibility of a bisexual orientation. But it has a category. It involves rigid categories for gender, and a person might not judge their sexual partner's attractiveness or interest in sexual partners or dating partners based on the gender. And so I would just say that some of the various functions that might be guiding your efforts to talk about sex with clients, sexual behavior, is sexual health, so sexual disorders or STI or HIV prevention. It could be from the perspective of reproductive health and contraception, or it could be from the perspective of sexual pleasure, which is one that's often neglected. And I think that one can feel least comfortable for those of us if clients aren't bringing it up, which makes sense to me. So just noting that we're just about out of time, but I wanted to note a few resources for you. And so there are the APA, the American Psychological Association, has guidelines that came out in 2010 about working with clients, with sexual minority clients. It uses the terminology of that era, so lesbian, gay, and bisexual clients, and that's freely available on the APA website and other places. And it gives guidance to psychologists, but it's been translated into like 20 languages, and so I think it's been useful for a lot of folks. And so I won't review those, but I would encourage you to review them. And just say that I'm on a committee where we're updating them for 2020, and I don't quite think they'll be out until 2021, but they're really good. So when they come out, I hope you will see them and then that you will use them. There's also some resources that I really like. I like this Craig Austin and Alessi article, just giving guidance about how to work with sexual minority clients and making sure to affirm identities even during the assessment process. Clearly explain the phases of treatment, what happens and then what, and to really get buy-in and collaboration with youth, but really with everyone. Focus on personal strengths and support networks. That part's really important too. And distinguishing between problems that are environmental, my family is not supportive, and those that stem from dysfunctional thoughts. I'm depressed, right? I think I'm a shitty person or whatever. So it's important to kind of try and tease those out as best you can. Again, saying that it's not, that it is complicated. And that for those environmental problems, help clients to engage in active problem solving, make changes to decrease stress, increase personal strengths and supports, and build skills for interacting with the social environment. I'm going to skip a couple of slides because there's just one other thing I want to say to you, and then I want to make sure I have time for questions. And the slides will be available to you, so you'll have all of these to reflect back on later. So I want to show you that that there's an article from 5 years ago that I really like, in terms of, like, very often at the end of a talk like this, people say, I really want to learn more. And so and there's that idea that we were talking about together earlier about how people about how training programs often don't address sexual orientation in ways that are useful. And so about 5 years ago, these folks are at the VA, Massa, Sloan, and Cowles, 2015, published a paper where they reviewed key reports, but also webinars like this. They reviewed 26 reports and webinars to identify these core themes. And they used those themes to evaluate 27 webinars and to kind of grade them in terms of A, B, C, to make recommendations about which are the most comprehensive. And so I encourage folks to check out that article if you can, to figure out which of the programs would be useful, with the caveat that 5 years later, some of that content might be outdated. And that's it. So I'm only 5 minutes over, which is probably the least I've ever been over in my entire life. And now I would be happy to take some questions.
Great, thank you.
By chat. Sure.
So we do have a few minutes for questions. I just want to preface this by saying I don't think we'll get through all of them, but if we don't get to your question, please feel free to email us at webinars@adaa.org, and we will get those questions over to Dr. Pantalone. So the first one, any good resources on intersectionality for the BIPOC community who are SM individuals?
Yes, there are. There are and there aren't. So I would say there's a new set of APA guidelines. I mean, I'm not sure about the professional organizations that you all frequent, but I'm a psychologist, and I've done a lot of work at APA. There's a brand new set of guidelines for addressing race and ethnicity that just came out, I think, in 2019, and they're so good, like so good. And so I would encourage folks to check those out. And there's a lot of good content related to intersectionality in the new LGB guidelines that aren't out yet, but that will be. I think they'll be out in the winter. Hope, fingers crossed, that part of the new guidelines that we have been revising are that we took a minority stress framework and an intersectionality framework for all of them. So I think that that those resources, one is useful even now, because I think that the race and ethnicity guideline folks did a good job of building in sexual orientation.
When writing assessment reports, I have always taught my students not to include sexual orientation unless it is relevant to the referral question. A student suggested that this inherently implies stigma and that we should routinely include sexual orientation in every report. What are your thoughts?
It's so interesting. I could see it either way. I think the student has an interesting point, because my guess is the consumer of those reports would assume heterosexuality if a sexual orientation isn't mentioned. And I would think that I would probably check with the client about whether they're comfortable having their sexual orientation in the report if they're a sexual minority person or a gender minority person for in terms of gender identity. But yeah, I think probably leaving it out would mean that readers would assume that kind of compulsory heterosexuality. And so I guess I'd encourage you to include it, but with consent. I'm just thinking about my days at the VA, and in other settings where, and it was one of the slides that I didn't have time to review with you, but about how confidentiality and record keeping can play out in more complicated ways for sexual minority folks. And so I think informed consent is the best way to go, really. So just to ask the clients what they're comfortable with. But in general, I would err on the side of including versus excluding. A good one.
We'll take one more question just to keep us on time. And then again, if we didn't get to your question, please feel free to email it to us at webinars@adaa.org. Any tips on addressing client microaggressions in session? For example, a parent makes negative comments about a child or client makes assumptions about clinician.
Yeah, it's so hard to, it's the kind of famous, it depends. You know, it depends on your relationship with the client. It depends on the duration of treatment and the modality of treatment. You know, if it is family therapy and the unit that you're treating is the system, then I think probably it makes sense to intervene, probably in that moment. But I think also just that I was, for example, trained really strongly in the DBT tradition where radical genuineness is valued. And so like if the client microaggresses against me, especially if I had a good relationship with the client and felt like it wasn't going to be rapport killing, I might just address that in session and say, I'm sure you didn't mean to, do that obviously, but as a gay man, I wasn't really comfortable with that thing you just said. And I wonder if we could just, take a pause and talk that out for a second. So I would encourage addressing it. I think especially just again that kind of I'm not really a kid or family person, but just thinking about the inherent power differential in the family. So if it is the parent especially making the comment, it could be so hard for the child to talk about their distress at the parent having made that comment. And so I would imagine that the therapist kind of scaffolding that response, either building skills for the kid to bring it up or kind of intervening in the moment and having a timeout for processing that you facilitate. But these are such good ones. And I would be so happy to answer the other questions. I've been trying not to be distracted by the chat box the whole time, but I would be happy to answer the rest by email.
Thank you. And thank you to our participants for attending today's training. We would like to invite you to register for ADAA's next live webinar on October 22nd, addressing racism to reduce mental health inequities. We also invite you to visit adaa.org to view all upcoming live webinars, as well as our full library of on-demand webinars. We would also like to invite you to the 2020 Virtual Fall Forum on Anxiety and Worry in Youth on October 29th. An interdisciplinary group of speakers will present on the biological and psychosocial mechanisms and interventions. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to continuing education webinars, including complimentary CE webinars, access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual conference, website listings of your clinical trials, support groups, and publications, and much more. Please visit adaa.org to learn more. On behalf of ADAA and our presenter, we thank you for joining us today.